Awesome. Thank you. All
You're
right.
welcome.
Well, good evening, everyone, and good afternoon to those of you joining from the West Coast. Welcome to our quarterly Kidney Health Coach Collaborative. So today we're very excited. We'll be presenting on APOL1 Mediated Kidney Disease, or AMKD, and we'll also be announcing the upcoming and very first Awareness Day for AMKD. So very excited about that. But thank you all for joining. So we like to start each of these collaboratives by introducing our AKF Kidney Health Coach team. So I'll get us started. My name is Ria Suarez. I lead our Kidney Health Coach and Kidney Kitchen programs. I'm the Associate Director of Public Education here at AKF. And I will pass it to Ryan.
Thanks, Ria. And hi, everyone. I'm Ryan Woolley. I'm the Director of Public Education. Good to see all you coaches on the call today. And I'll pass it to Sana.
Thanks, Ryan and Ria. And hello, coaches. So nice to see you all today. My name is Sana Sadiq, and I'm the Public Education Specialist. And thanks again for tuning in this afternoon and evening.
Great. Thanks, team. So if this is your first time joining us, hello and welcome. We'd like to give you the opportunity to introduce yourselves. So if you would just drop your name in the chat, where you're located, and how long you've been a coach, that would be great. And as you're doing that, for those of you who this is your first time joining, our Kidney Health Coach Collaboratives, these are our ongoing virtual events where coaches like you come together to connect with other coaches, connect with us as AKF staff. It's an opportunity to expand your knowledge in kidney disease and related topics so that we can better support all of the great work that you're doing in communities. So we definitely want to ensure that the content presented is applicable to you and all of your efforts. So we have a quick survey at the end that we do ask you to complete, as it helps us improve these events. Sure. So let's see. I can't pull up the chat, but let's see who we've got. Here we go. So welcome, Christopher, joining us.
Hello. Welcome,
Kimberly, Brenda, Nicole, Raya. Oh, 5 years. Great work. Nicole Bates, good to see you. Tierney. Hello, everyone. Welcome. Feel free to continue to drop your name as we discuss today, and feel free to drop in any questions you have as well. All right, so for today's agenda, we covered our welcome and introductions. Next, we'll have Sana go over some announcements and introduce Dr. Silas Norman, who will be giving our overview of APOL1 mediated kidney disease. And then we'll discuss our community toolkit and then end with some questions and answers and some reminders as well. So I will pass it over to Sana for some announcements.
Awesome. Thanks, Ria. So just a quick few announcements before we go into our presentation today. First, we are proud to launch enhancements to our Kidney Kitchen website. If you're not familiar with Kidney Kitchen, it's our comprehensive resource on kidney-friendly eating and nutrition. Some of our enhancements include easier navigation and search function throughout the site to help you find the information you need more efficiently, refined search and filtering on the Find Recipes dashboard to help you find recipes that match your kidney-friendly eating plan, and improve access to our extensive guides and videos resource library that has information on kidney-friendly eating and nutrition as well. So you can check out all of these features and more enhanced features on kitchen.kidneyfund.org. I'll also drop that in the chat. And in case you missed it, AKF hosted our 5th annual Kidney Action Week on March 18th through the 22nd, 2024. We have all of the recordings from Kidney Action Week available to watch, with session topics including dialysis, kidney disease prevention, kidney-friendly eating, the transplant process, and kidney disease innovations on our YouTube playlist. I'll be sure to share that in the chat as well, so you can check those recordings out. And we also want to remind our coaches of some educational resources that have been recently made available on the Kidney Health Coach portal, including our Clear Communication Guide, which shares helpful clear communication strategies you can use to make sure people understand the information you share. We also have 2 conversation starter guides for preventing and managing CKD. Those are also available on the Kidney Health Coach portal. And these resources share key talking points and are helpful when you have limited time to share information about kidney disease. Lastly, for all of our healthcare professional kidney health coaches, we have developed a new guide to learn how to better understand your patient's background, how to tailor your teaching methods, and what to discuss with your patients. So like I mentioned, all of these resources are available on the Kidney Health Coach portal, and we encourage you to not only use these resources yourself as a kidney health coach, but to also share them with your community and networks. And now we are very excited to transition into today's presentation on APOL1 Mediated Kidney Disease, or AMKD. And presenting on this topic, we are honored to have our guest speaker join us today, Dr. Silas Norman. Dr. Norman is a transplant nephrologist, clinical professor of medicine, and the co-medical director of kidney and pancreas transplantation at the University of Michigan. Dr. Norman is the chair of the AKF Board of Trustees and a past chair of the American Society of Transplantation's Inclusion, Diversity, Equity, and Access to Life Committee, which works to minimize discrimination and improve equity and access to transplantation. Dr. Norman's research is focused on reducing health disparities in kidney transplantation and the evaluation of medical frailty. Dr. Norman is also a member of the Minority Organ Tissue Transplant Education Program Detroit Foundation Board and the Board of Directors for the National Kidney Foundation of Michigan. Dr. Norman, thank you so much for being here to present important information about APOL1 mediated kidney disease to all of our kidney health coaches, and I'll hand it over to you to start your presentation.
Great, thank you. Thank you for that very nice introduction. Welcome, everybody. Thank you for joining us tonight, and thank you for the opportunity to spend a few minutes speaking with you. And thank you for all the work that you do day to day in your capacity as health coaches, which is really critical to helping people be empowered in their health care. So for tonight, let's see. Nothing in particular to disclose as it relates to our conversation this evening. And what we'd like to do tonight is spend just a few minutes talking to you a little bit about the background of APOL1, to describe the association of APOL1 with chronic kidney disease, and then to give you some ideas about the application of APOL1 testing to the kidney donation and to the kidney transplant recipient evaluation process. So starting out, as we think about the importance of APOL1, is really thinking about what is the evidence that APOL1, as it relates to susceptibility to kidney disease, particularly in African Americans. We know that when we look at individuals who have high-risk variants of APOL1, and we'll talk about what that means specifically in just a minute, but we know that those individuals with high-risk variants of APOL1 have an increased risk, increased likelihood to progress from early to late stage chronic kidney disease to end-stage kidney disease. We know that when we look at the African American community, that we've seen over decades really persistent high incidence rates of chronic kidney disease in our community. And then I think a couple of interesting observations that we've seen for a long time that APOL1 may help explain is think about this familial aggregation of end-stage kidney disease independent of socioeconomic status. And what that means is that, and I think we've all probably seen often, is that it often seems that there's a lot of chronic kidney disease in families. And one of the things that's been observed over time repeatedly is that unlike a lot of diseases where as people move from being impoverished to being in the middle class to being upper middle class, so forth, as people move sort of where they live, these kind of things, these other socioeconomic markers of negative health outcomes. What you see is despite individuals maybe doing better socially, economically, you still see this strong family aggregation of end-stage kidney disease, suggesting that there's something else going on besides some of the environmental factors. And then the other thing that we've seen is this clustering of kidney disease in families, which is to say you may have a number of people in a given family who have disease, who have kidney disease, but they have it for different reasons. And so you may find in a particular family, one person has kidney disease attributed to diabetes, one has kidney disease attributed to high blood pressure, one person has kidney disease as a consequence of their HIV, one person has it from their lupus. And so although the causes are different, it seems like there's some propensity when you get a disease to then develop kidney disease. And so that's one of the things that makes us think about, is there an underlying genetic factor that may be contributing? Next slide. So what is APOL1? So we talked about APOL1. So APOL1 is a short name for apolipoprotein L1. And this is a protein encoded by the APOL1 gene. It's on the 22nd chromosome, and as you can see by the picture here, APOL1 is a protein that really sits on one of your cholesterol molecules. We often talk about HDL as being the good cholesterol, and so on this molecule, everybody has APOL1 molecules also. Because we have two copies of sort of everything, right? One copy we got from our mother, one copy we got from our father. Everybody has two copies of APOL1, which may or may not be exactly the same. But it's in and of itself a normal thing for all of us to have sitting on a cholesterol molecule. Next slide. So what happens that makes it riskier? Or we talk about these variants. And so it turns out there's two variants to the normal APOL1 gene. So the normal APOL1 gene, which is just called G0, that's the so-called wild type. This is the kind that you would just find out in the community. And then over time, there's been development of two different variants of APOL1, G1 and G2. You can see pictured, they just happen to have sort of slightly different abnormalities that make them variants. But both the G1 and G2 are recognized as what we call high-risk variants. And what we mean is that people who have these variants are at higher risk for developing chronic kidney disease. Because we get two copies, one from our mom, one from our dad, if you look at on the bottom of the slide, what you can see is that any given person, either has two G0s, or they have a G0 with a G1, a G0 with a G2, et cetera. And you can see that there's a couple ways you can have two high-risk variants, which is that you could have two G2s, you could have two G1s, or you could have a G1 and a G2 pictured on the right. And all of these would be considered high-risk variants that having, two G1s or two G2s or that combination is going to put you at higher risk for developing chronic kidney disease. Next slide. So then we look at, why did we start talking about just African Americans as we talk about APOL1? So the story is kind of interesting. So you can see pictured here the continent of Africa, and it turns out there is a parasite called trypanosoma, and trypanosoma brucei causes a disease called African sleeping sickness. It's a disease that can make people very sick and can lead to a lot of mortality when not treated, and treatments aren't great. And it turns out that people who carry these high-risk variants, the G1 or the G2 variants, actually are relatively resistant to African sleeping sickness. And so the reason that we think these G1 and G2 variants developed and persist is because, in fact, in Africa, in these areas where there's a lot of trypanosoma infection, these are actually protective mutations to have as it relates to that infection. And these are relatively new variants as these things go, appearing about 60,000 years ago. And what you can see pictured on the right, Trypanosoma brucei really is distributed in sub-Saharan Africa. And what you see pictured on the slide to the right in all these little pie charts tell you red is kind of the wild type, and then blue and green are these high-risk variants. And you can see, particularly if you look, say, at the western edge of Africa, you can see there's areas where there's a lot of G1 and G2 variants over there, which corresponds to areas where there's a lot of infection. And then if you look at that and you think about the transatlantic slave trade and where individuals, particularly from West Africa, would have come to the Americas and the Caribbean and so forth, then you can see where we would have also brought over these protective, but now we recognize high-risk variants of APOL1. Next slide. Similarly, this just gives you another idea, a couple slides. There's a couple different trypanosomas. Those don't matter so much. But if you look at that, at the lower two bars, the APOL1 G1 frequency and APOL1 G2 frequency, if you look at those different color bars, and just kind of look at where in there you see red and orange, and kind of the dark yellow color there in that distribution across places in Africa. And you can see that there are some communities in Africa where you may see 5, 10, up to 30% of the population has one of these variants. And that really directly corresponds to kind of the green, where you see a lot of this parasitic infection. Next slide. Looking closer at the kidney. So why do I show you this? So this is an electron microscope picture of a kidney filter. So we talk about kidney filters, and you all probably recognize that when we talk about the kidney filters, they kind of look like a cauliflower, and they're just blood vessels that are all twisted up. And I usually use the analogy of thinking about a balloon animal that, if you take sort of one of those long balloons at the circus and then you twist it up into a giraffe, you know that sort of the left leg and the tail, it's all the same balloon. And your kidney filter is kind of the same way. And what you see on this picture labeled with P is it kind of looks like a little roll with a bunch of little, maybe an octopus or two laying on top of that. Those cells, those ones that kind of look like an octopus, those are kind of the most important functional cell of the kidney. Those are kind of the cells that sort of hold your kidney into the filter in the round shape that it's in. They're really metabolically active. And so this is a site, as we'll see, where APOL1 might cause directly its kidney injury. Next slide. So if you look on the left, this kind of shows you what APOL1 does sort of in its natural state. The little wiggly thing there is just a drawing of the trypanosoma parasite. And what you can see sort of in that little blow up is that you have that HDL molecule that has the APOL1 on it. And what those variants do is they basically can put holes in part of that trypanosoma organism that makes it easier to be damaged and destroyed by your immune system. And we think that in the same way, although the exact location is not entirely clear, if you look over on the right side, this is just a different picture of that octopus, kind of looks like Pac-Man. But what you can see there is that, again, if you look at those three little tubes, you can see there's a couple different areas in the kidney filter where the APOL1 variants are probably damaging or putting physical holes in parts of your kidney filter, and that's how they're driving disease, we think, in the kidneys. Next slide. So we know these variants can drive disease, and so the next question is, how important is this? So among people of African ancestry, and although we end up talking often about African Americans, we really want to be thoughtful that we're really talking about people with African ancestry from these areas that have been affected, and sort of the idea of sort of ethnic identification and skin color are one way to think about that, but we're really talking about African ancestry. But among folks who have African ancestry, somewhere around 12 to 14% of folks in the US, predominantly African Americans, but we think about folks in the Caribbean also who may have some of these genotypes. So 12 to 14%, or maybe 1 in 8 people have 2 copies of these high risk variants of APOL1. And we know among those people who have the high risk, about 15%, or about 1 out of every 6 people who have those high risk variants are likely to develop end-stage kidney disease. So it's pretty substantial risk among folks, and there's a pretty high frequency of people who have these high-risk genotypes. Because of that ancestral origin of APOL1, what you see is the likelihood of having 2 high-risk variants among African-American populations is nearly non-existent, because even for mixed race individuals, at most you're going to have 1 high-risk variant likely. So this seems to be largely driving a lot of issues in African-Americans. And then when we think about what APOL1 does, we think about it as what we call a progressor gene, which is to say that it seems that just having high-risk APOL1 variants in and of itself is not enough. Something else has to happen. There has to be a second hit, a second injury. For some folks, that second injury may be the development of HIV. It may be the development of lupus, but it seems like the high-risk alleles alone aren't enough, but they certainly set you up for kidney disease when something else happens. Next slide. So people who have 2 of these copies, G1 or G2, are at particular risk of non-diabetic kidney disease, sort of separating out all the folks who have diabetes, kidney disease driven by diabetes. So non-diabetic kidney disease, and it's kind of striking when you look at some of these numbers. So for folks who develop end-stage kidney disease attributed to high blood pressure, 7 to 10 times the risk of folks who don't have high-risk genotypes. That's really kind of amazing. FSGS, what we call focal segmental glomerular sclerosis. That's just a pathology term of what the biopsy looks like, but these are people often in the age range of kind of 25 to 44 who develop kidney disease associated with spilling a lot of protein. It can progress reasonably quickly. You can see that in folks who have these G1 or G2 variants of APOL1, 10 to 17 times the risk of developing FSGS than people who don't have it. And then if you look at folks who have HIV, there's a particular kind of FSGS that folks who have HIV often get that's a very rapidly progressive form of kidney disease. And you can see nearly 30 times the risk if you have one of kidney disease, if you have the G1 or G2 variants. And so it's pretty profound. And really impressively, APOL1 really may explain about 70% of the excess risk of kidney disease that we see in individuals of African descent. And so without discounting those socioeconomic status factors, built environments over that can impact things, as we think about why do African Americans have so much kidney disease, these high-risk variants of APOL1 really may explain a substantial amount of that excess risk. To compound the story of kidney disease, there's also some association with the APOL1 high-risk genotypes with an increased risk of cardiovascular disease as well. And so, learning about these, knowing about these, working to manage this risk is perhaps important even beyond minimizing kidney disease. Next slide. So this is just a study of APOL1 and chronic kidney disease in healthy individuals to give you sort of an example of kind of the risk we're talking about. So you can see here 3,400 individuals in the general population, relatively young population, about 25 years old, 48% were African American. And what you can see is we have European ancestry, women, men, African-American women and men. And if you look at the second column with the population risk of chronic kidney disease, you can first start out by looking at that population risk, and you can see lowest risk in women of European descent, sort of 0.3% over their lifetime. You can see that European men and American women, that's a bit higher. And then look at African American men. That risk sort of at baseline is sort of 3 times higher. And then if you move over and think about what happens with the risk variance, you can see that if you have one APOL1 high risk variant, you can see in African American men and women, you can just look at that effect. Perhaps 3 times the risk just having one variant. Your risk of kidney disease has gone up 3 times from baseline. And then if you look at having 2 APOL1 risk variants, again, you can see that risk has gone up perhaps 12 times from the baseline risk. So it's really substantially impactful. Next slide. And then this is just to show you, these are from biopsy findings, kidney biopsy findings, that APOL1 is associated with a lot of different kidney disease. So the FSGS we talked about, a strong association with focal segmental glomerulosclerosis. And again, this often impacts young people. This collapsing variant of FSGS, this is what's most commonly associated with HIV infection. And one of the interesting things I'll say about that is it's been observed for a long time that in folks with HIV infection, it's almost exclusively African Americans who develop collapsing FSGS. And we've known that for a long time before we knew about APOL1. So we had this observation. You can see this global glomerulosclerosis just means that your kidney filters are getting scarred down. So we've seen that. And then you can see that in other disease states, folks who have lupus, that getting lupus-associated kidney disease might be more frequent in folks who have these high-risk genotypes, and even in folks who have sickle cell. And sickle cell actually has a very similar interesting story in terms of ancestry in Africa and the prevalence that we see here. But you can see that folks who have high-risk APOL1 genotypes and also have sickle cell are at even higher risk of developing kidney complications of sickle cell than folks who don't have the high-risk genotypes. Next slide. Just to show you that, again, there's a spectrum of disease that's been associated with these high-risk APOL1 genotypes, everything from increased risk of preeclampsia in pregnant women to sickle cell, as we talked about, to what we see in HIV, in this progression to end-stage kidney disease. So a spectrum of disease, but likely with a similar underlying mechanism. Next slide. So just turning that from the general population to the transplant population, which we're looking at, as the best treatment for end-stage kidney disease, and what impact does knowing about or thinking about APOL1 have on those populations? So when we evaluate folks as potential living kidney donors, the main thing we want to do is minimize the chance that those individuals develop kidney disease over their lifetime. And we know sort of at baseline, our estimation is that our African American candidates are at baseline higher risk of chronic kidney disease. So when we think about how we estimate the risk for potential donors, knowing their APOL1 genotypes will help us estimate their risk and at least it help inform people of potential higher risk. Donor access. So one of the things we have to think about, as important as it is to protect our donors and make sure that people are well informed about what they're doing, it is likely that as we get better at and more consistent with testing APOL1 in potential donors, there's probably going to be otherwise healthy African Americans with 2 high-risk genotypes, 2 high-risk variants of APOL1 that may get declined as potential donors who we otherwise would have cleared. And that can be a perfectly appropriate thing to do, but that may exacerbate access to living donation, particularly among African Americans. There's questions about testing. Who do you test? When do you test? How to think about the testing, particularly as there's no particular treatments right now. Sharing information. If you receive a kidney from someone who had high-risk APOL1 genotypes, do we need to talk to the recipient about that risk? And then one of the things as we think about race and risk is that I think this is important, is that rather than thinking about African Americans as having a higher risk, as if that's a biological thing, it's really more accurate in this case to start thinking about individuals who have these high-risk genotypes are at higher risk, because it may be the fact that African Americans as a group are not at overall higher risk for end-stage kidney disease. It is individuals who have particular high-risk genotypes who are African American who are at high risk. So that helps to kind of disentangle skin color from risk and really looks at really genetic underpinnings and risk. Next slide. This is important. So this just looks at what happens to living donors after they donate. This looks over sort of a 25-year period of individuals who have sort of wild type normal, G0 APOL1 genotypes and those who had the high risk. And you can see this is looking at kidney function at GFR. Higher is better. You can see that there's a difference in the GFRs of these donors based on their APOL1 genotypes. And you can see there's also the slope is different, right? That the folks who have high-risk genotypes, that their rate of decline of kidney function over time is greater than that in folks who have low-risk genotypes. So this could be important, and it might be particularly important if you're talking about particularly young donors, right, who have a long period of potential decline. Next slide. There may be some changes coming, as it relates to how we think about stuff in the transplant field. Currently, when we think about, there's something called the KDPI, or the donor profile index. Those of you who've been transplanted might be familiar with it. It's a way for us to measure donor quality. And you can see over on the left-hand side kind of all the things that go into it. One of the things that goes into that is whether or not you're African American. If you're African American, we say that kidney is going to be of lower quality, sort of up front. We recognize now, of course, that's probably not a good way to do it, that what's probably driving this risk as we look at it is probably the APOL1 genotypes, and that's what's driving it. And so, we expect that probably over time, these kind of considerations that we're going to drop ethnicity and race from it. And what the question will be, do you have 0, 1, or 2 high-risk APOL1 genotypes? And that's how we'll look at donor quality. And then we think about transplant outcomes. And so one of the questions that this APOLLO study is trying to answer is that for individuals who, in addition to the question about what happens to the donors, is the question is for individuals who receive kidneys from people with 1 or 2 high-risk APOL1 genotypes, what does that mean for our expectations for their long-term transplant kidney function? And how do we need to think about that? Next slide. When we think about transplant recipients, again, there's some early studies that look at this, and many of them seem to suggest that you may have a faster risk or a sooner time to graft failure after transplant if you receive a kidney that has these high-risk genotypes. These are early studies. These are small studies, mostly retrospective or looking back studies. But there's at least some suggestion that these kidneys might not be lasting quite as long. What that difference is and exactly what that means is not known, but there's some suggestion that we need to probably be thoughtful about that. The studies weren't all consistent, but there's at least some suggestion. And then there's some suggestion that coming into it, that part of the reason for that more rapid decline, maybe these kidneys that came from people with high-risk genotypes. We saw that slide where the APOL1 was damaging the podocytes, damaging those cells of your kidney filter. It may be that by the time you get that kidney, that damage is what's driving sort of the worse outcomes that we're seeing in some of these studies. So a lot more studying to do, but a lot of information for us to kind of think about and sort of be aware of as we move forward. And then as we move forward, potentially as patients, that we're thoughtful about, asking some of these questions about what kind of kidneys we're getting and what was thought of and considered. Next slide. And then finally, just some of the ethical concerns. So should testing be routine? What does that mean? So there's some ethical concerns, among other things. If we do this testing, what does that mean for health insurance, for life insurance, for employment? If we say up front that this is associated with a higher risk of chronic kidney disease, and then we test and find out you as a perfectly healthy person have 2 G2 variants, what does that mean? Is your health insurance, potentially in the future get adjusted, or your life insurance, or you get declined for life insurance? What does that mean for your employer in terms of how they price health insurance and so forth for you? So a lot of things to think about before jumping in and wholesale saying, let's test everybody. Financial. So there's the cost of the test themselves, and not everybody has access to this testing. And so what does that mean for equity? If we decide we want to test everybody, who's going to be potentially left out of that and not have a chance to know what's going on with their risk? There's some questions sort of selfishly for programs like ours, transplant programs. What does this mean for your transplant programs, your transplant outcomes? If you're testing or not testing, how do you look at that? And then I think importantly, because, remember, we talked about, 12 to 14% of people have these high-risk genotypes. We talked about, among those, 1 out of 6 people are going to develop end-stage kidney disease. But we don't know which of those 1 of the 6, right? And so part of our problem now is we don't have good models to help predict, identify, are you 1 of the 6? Or are you 1 of the 5 of the 6 who, even with those genotypes, we're not going to get disease? And so I think it's important as we think about doing a lot of testing. The question is, okay, so what do you do with the testing now that you have it? What do you tell the person? How do you counsel that person if you're really missing, a lot of the subsequent information to really help them gauge their risk, except to say, you have these high-risk genotypes. I'm not 100% sure what it means for you as an individual. Next slide. And then finally, how do people feel about it? So one of the questions was, we talk about it as physicians, like, how do people feel about this testing and getting tested? So there was a study that Elisa Gordon did, and she really just asked people about their feelings about getting tested. And what she found was that in her study was that, hypothetically, if offered, most participants would have undergone APOL1 testing during their donor evaluation to help them make a more informed decision. But many would have said, regardless of the results of that, they would have still moved forward with donation. People, generally speaking, had wanted more information about how having 2 high-risk genotypes was going to affect their health and the potential recipient's health. And then for patients who were referred, kind of thinking about these issues of genetic ancestry, thinking about racial, ethnic identity, thinking about risk. Some people thought, maybe everybody should undergo this testing so we're clear about the real risk. But then importantly, as we talked about the ethical considerations, a lot of people were worried about, what does this mean in terms of potential out-of-pocket costs, both for testing, but also for sort of the consequences of that testing, and could this, end up being a pre-existing condition, as we talked about, that might lead to potential discrimination, because it's going to be one group that might have the impact of higher insurance rates and life insurance rates and so forth. Next slide. So in conclusion, these APOL1 gene variants are common in individuals of West African ancestry, 12 to 14%. These genotypes are associated with an increased risk of chronic kidney disease and end-stage kidney disease. We said roughly 1 in 6 people with these genotypes is going to develop, end-stage kidney disease. Thinking about APOL1 has really serious implications as we think about living kidney donor evaluation and transplant recipient outcomes. And then I think importantly that there are some ethical and financial considerations that really need to be thought about as this testing, becomes more frequent. Thank you.
Great. Thank you, Dr. Norman. Thank you
And
for
I'm happy
that.
to take any questions.
Sure. Thank you for that very informative overview of APOL1. I know that I learned a lot, and I'm sure our coaches did as well. And I'm sure that they have questions. But before we get to those, we are very excited to announce that AKF will launch a National AMKD Awareness Day on April 30th. So that'll be next Tuesday. This will be the first ever AMKD Awareness Day. And this day is aimed at increasing understanding of APOL1 gene variants and their association with kidney disease among these groups. So with that, I will now turn it to Nancy Gregory, who is AKF's Senior Director of Communications, and she will discuss how you can join us in being APOL1 aware. Nancy.
Thanks, Leah, and hi, everybody. Hi, coaches. I'm going to share my screen in a second, but first I just wanted to give you a little bit of background about AMKD Awareness Day. This is an extension of our APOL1 Mediated Kidney Disease education campaign that we launched in 2022, and that includes information about AMKD, free downloadable materials, patient videos, an animated APOL1 explainer video, a guide on AMKD and genetic counseling, as well as a professional webinar on AMKD implications for patient care. So we wanted to further amplify awareness about AMKD, and we launched this National AMKD Awareness Day on April 30th with support from Vertex. This campaign is aimed, as Ria said, at increasing recognition of AMKD and understanding of APOL1 gene variants and their association with kidney disease among these key risk groups. We are encouraging all to become APOL1 aware and get a better understanding of how genes may impact kidney health in communities at risk. So our AMKD Day activities include, typical like media outreach and social media engagement, partner collaboration and outreach, as well as advocacy efforts on the state and the federal level. And over the past couple of months, we have been working to disseminate our AMKD Community Toolkit. And just want to make sure you can see my screen. You can see the toolkit?
Yeah.
Okay, great. This is available on our website, kidneyfund.org/APOL1 Aware. And the community toolkit is right, one of the first things you see when you go on the website. Click on it and you'll get to this PDF. And first we have, I'm just going to walk you through it, a little explainer, and now you are all very well versed on AMKD after Dr. Norman's presentation, but it just has a little bit of background about what is APOL1 mediated kidney disease, who it affects, a little bit of background about the day itself. We specifically decided to do it in April, which is National Minority Health Month. We felt that that was very apt, and moving forward, it'll be observed on the last Tuesday of every April. So with this toolkit, whether you're just an advocate individually or you're an organization, it has a lot of information that you can use to amplify the day. So we have social media posts, key messages, content for newsletters, and all that stuff. So here you'll see social media posts. These are posts that you can use up until Tuesday. All you have to do is just, copy and paste. You can also customize those messages. And then throughout the toolkit, you'll see the download button, which means that'll take you to a shared folder, which has all of our assets. So images, logos, PDFs, Zoom backgrounds, and things like that. And we'll go back to that in a second. And then we also have a special day of sample post for April 30th. If you do anything, we'd just love for you to share on Tuesday that today is the nation's first AMKD Awareness Day, and share this graphic. We have, specifically like character amounts, posts for Facebook and Twitter, or X as it is now known. And even though LinkedIn is not mentioned here, we do encourage you to share it on whichever social media networks where you're most active. And here we have newsletters. So if you are if you work somewhere where they put out a newsletter where they are open to taking submissions, you could submit this, just copy and paste this blurb. We have some for the professional audience. We have a sample community email letter. And then we also have in the assets folder email headers, so graphics that you can download high res that go along with your emails. If you have your own newsletter, you could use that for that, or if you have a blog. We also have an AMKD Day poster and an AMKD infographic. So this poster, it's available in 2 sizes, so 8.5 by 11 or 8.5 by 14, which are the most common home printer sizes. So if you have if you work in an institution that has a community bulletin board, or if you're going to a clinic where they'll allow you to hang these, we'd definitely love for you to circulate those. The infographic can be shared on social media. And then we also made our logo available for download. As you can see, a few of us have the Zoom background, if you'd like to do that. And then we also have a cover image. And then some of the resources that we included in the toolkit are from the APOL1 Mediated Kidney Disease Education Campaign. So you can download the genetic counseling guide. We also have videos that 3 patients graciously recorded for us, where they talk about their journey with AMKD. You can share those from our YouTube channel. And this is our animated explainer video. And I know I'm going really fast. I'm just kind of rattling through those. So if you need to stop me and ask a question, that's totally fine. We also have the tips for talking to your doctor about APOL1 mediated kidney disease. And then we have opportunity if you have AMKD, or if you know anybody that has AMKD and they would like to share their story on video. This is a really easy way to provide user-generated video. This goes to a platform called Boast, where it enables a camera, and then it gives you a little bit of a prompt as to what you might share, like 1.5 to 2-minute videos. And we have those on our website as well. So I want to just kind of show you our assets folder, where you find everything, and it's linked to from the PDF. So for example, our newsletter email header. And then we have the logo in many, many sizes and formats if you need that. But this is our primary logo. And then we have it digital, and then a lot of folders. And there's our logo that you can download and share. And I wanted to also show you the Zoom background, which I know you can see, but it's very easy to just click on that, hit the down arrow, the download button, and then upload it to your, whether it's Zoom or Microsoft Teams, if you're in a meeting on Tuesday and you want to show your support. We have also on here, I want to show you the poster. April 30th, the APOL1 Aware, join in, and then has our website. And then here is an infographic that kind of gives you a little bit more information about what is AMKD. Has a few of those stats that Dr. Norman mentioned as well. And we are starting to see some folks share the assets on social media, and we love to do that. And then we also love to amplify it. So I encourage you all to share and then tag us so that way we can repost, reshare, and say thank you. And that is it for me. If anybody has any questions about the toolkit, I'm happy to answer those on this call, or you can also contact me via email. And then I know if there's any questions for Dr. Norman on APOL1. I think we have 5 or 10 minutes.
Great. Thank you, Nancy. Thanks for walking us through the toolkit and showing us all the different resources and graphics that we have. So let's move into our question and answer session. If you have any questions, feel free to drop them in the chat or even come off mute if you would like. We've got some time for some questions. All right, so I will start off. Oh, go ahead.
No, I was just going to point you to the chat. I think I see one in the chat, and I'll put one of my own in there too.
Okay, great. So let's start off with this one here. Are there any trials for medication for APOL1, Dr. Norman?
Yeah, so currently no medication trials for APOL1. So as important as APOL1 is, it's really, we're really early in it. We're really in the first like 10, 15 years of it really being discovered. So I think one of the challenges right now is that there are no specific treatments. So it's sort of the, what do you do with the information right now? And I think it's relates to one of the second questions about this information, embedding this information into primary care consults. I think we're currently in the state with APOL1 really just getting people aware of their risk, letting people understand you may be young and healthy, but you potentially carry these risks. And so being aware, and particularly as people think about, do I also have high blood pressure, diabetes, or other potential things that might drive it? So really about the awareness right now. And then I think there's no current consensus about how broad or narrow to make the testing, how early to start the testing. I think those are some of the critical questions that people are trying to answer right now. But there's some early. There was a Delphi conference that tried to put together some consensus recommendations, but again, it's sort of very early in the stage for this.
Great, thank you. Another question here, what research is currently being conducted to better understand or treat APOL1?
Yeah, so there, so you saw all the AKF resources to kind of help with awareness. One of the biggest studies going on to help understand the impact, at least in the transplant space, is this APOLLO study, which is looking at Black potential kidney donors and typing those donors, giving them some information. And then if people donate, kind of looking at what the outcome is for the donors. And then similarly looking, at people who receive kidneys from folks who have these high-risk genotypes to see what happens to them, to kind of better understand the nuances of what's happening. And then there's a number of other kind of early studies getting started to really understand even just the basic, are these estimates of risk really good estimates of risk, right? Because they're relatively small study estimates of risk. And I don't think so far, you saw that one slide with the Pac-Man with a lot of suggested mechanisms of what APOL1 does. So there's some more basic science studies going on to just try to better understand, what specifically, what thing or things does APOL1 do as it relates to the kidney or the heart for that matter. Because understanding those mechanisms will be the thing that then lets you drive potential interventions.
Wonderful, thank you. How much of an impact does AMKD versus structural racism impact the disproportionate rate of kidney failure among African Americans compared to other racial groups in the U.S.?
Yeah, no, that's a huge question. And I think to just reveal my bias, so I'm one of the folks who's usually um, um, a little reluctant when people get a little too excited about sort of genetic differences in different racial ethnic groups, because I think often finding a genetic aha sort of lets people feel like they're off the hook for all the structural racism and socioeconomic disparities that we see, right? I think even at the highest current estimates, if which was to suggest that the APOL1 story might explain up to 70% of the differences we see in African American and non-African American outcomes as it relates to kidney disease. Even with that high estimate, there's still 30% that's not explained biologically. And we may find out over time as we test more people and we look at more people, see more people, that 70% maybe is an overestimate of the effect of APOL1. And so I think as we look at APOL1, which I think is important and it's a great finding and everything, we shouldn't at all lose sight of all the other things that we know impact people's care. Their structural racism, access to care, insurance, education, distance from medical centers, where medical centers are located, transportation, jobs, all the things that we know have impacts on people's risk of disease and outcomes.
Great, thank you.
Thank you for answering that, Dr. Norman, because AMKD is something that we should all be aware of, and it's the first awareness day coming up that we're hosting here at AKF. But the overall cause, I think, is important to keep into perspective, which is responsible for 4 times the rate of kidney failure among Black people in the United States versus other groups. So thank you for saying that.
Absolutely.
Wonderful. Any other questions? We'll wrap up here. Okay, let me bring back my slides. So as we wrap up.
Wait, I did have one question,
Oh,
if I can.
sure.
So is the APOL1 testing only during the transplantation period? And if so, is the donor and the recipient tested at that time?
Yeah. So in theory, APOL1 testing could be done anytime in any population. Where it is most frequently done, and it still varies across centers, is in the transplant context, is where it's most commonly being done right now. But even that, again, varies transplant center to transplant center, whether they're testing all of their African American donors, which some are. Less frequently with the recipients, where it's being tested most commonly in donors. Some people are making it optional for donors, so they're talking to them first and sort of get an idea of, do people want to be tested or not, kind of thing. There is variation in whether having tested people, whether if they have 2 high-risk genotypes, our centers excluding those people as donors or not. So there's a lot of variation in practice, and I think that's one of the things, because we don't have a lot of information, where I'm a little uncomfortable, a little concerned that we may be jumping the gun a little bit to take people that, so we've been doing living donor transplantation, right, for 70 years, just about. We have almost certainly, and we have a lot of African American successful living kidney donors. We have almost certainly taken people with high risk genotypes of APOL1 just by the numbers, and we know that although that risk is higher, it hasn't been prohibitively higher. The previous living donor end-stage kidney disease risk difference between Blacks and whites, for instance, is largely similar to the proportional difference in the general population. So it doesn't look like we've necessarily put a lot of African Americans at undue risk. We don't know that for sure, but we want to be thoughtful before we have this great new test and all of a sudden we're just excluding people based on a test that we don't know the outcome. So, but to answer your real question, is done a lot in transplant, but really, really highly variable. And I think that's one of the things we need to, at bare minimum, have some consistency around. so that we're treating kind of the same groups of people the same way, so they could really see, you know, what the impact and outcomes are.
And one follow-up question. So a recipient that has the two bad versions of this gene, would they be someone who would not be on a wait list? You know, like, would that be an excluding factor from being listed?
Yeah, so that would not be an excluding factor for being listed. And it's fair to say that most of the recipients who are being tested are being tested in the context of research where their donor has been tested. So it wouldn't exclude. I think the one thing it does do, and it'll be interesting to see. So although we have not added in APOL1 testing to how we consider deceased donor quality. We are going to nationally, we are going to eliminate race as a consideration from the KDPI calculation, which will immediately make folks who are African Americans donor quality go up, because so that's a good thing. And then we have to see, you know, how does that impact, you know, if we then add APOL1 back in as a donor consideration, that could have an effect on what kidneys we take for what people, what individuals.
Okay, all right. Thank you.
Great. Thank you, Dr. Norman, and thank you, Larry, for those questions. So I know that we're over time, but just to wrap us up, here are some next steps that you can take, and we highly encourage you to do. So be APOL1 aware and join us for the first ever AMKD Awareness Day. Educate others about AMKD through the education sessions that you're already hosting and all of the different interactions that you have with your patients in the community. And then share the AMKD Awareness Day messaging, which is found in the toolkit through your social media channels and your network. And then I will turn it to Sana to go over some reminders and close this out.
Thanks, Ria. Okay, yeah, so we have a short evaluation that's going to pop up on your screen. Please take just a quick moment to fill this out. Your feedback is very, very important to us as we continue to offer future collaborative calls and identify topics that are very relevant to you and your work educating the community. So please take a moment to complete the evaluation, and thank you all for joining us.
Thank you all. Thank you, Dr. Norman, and thank you, Nancy, for joining us today.
Thank you all for taking the time.
Bye-bye. And for our coaches, we'll leave this up, so don't feel rushed to have to complete this in 30 seconds. We'll keep this up for as long as people are completing it. Thank you all. Have a great evening.